Hello, my name's Hope Frost, and on behalf of SBK Healthcare, I'm delighted to welcome you to this Delivering Effective Point-of-Care Testing During COVID-19 webinar. We do hope that you find the video enjoyable and helpful. Please do share your thoughts in the comments and make sure that you like and subscribe so that you don't miss any new content that we upload. It is now my pleasure to introduce Kevin Bage, Product Manager, Blood Gas and Samplers UK and Ireland for Radiometer Limited.
Thank you, Hope. Good afternoon, everybody. Over the next 5 minutes, I plan to discuss how our products have been supporting you and other healthcare professionals during this very challenging time. I know that many of you will be familiar with Radiometer, but you may be less aware with the links that we have with other diagnostic companies that you can see up on the screen. And that makes us part of our parent organization called Danaher. This association certainly helps with the development of many point-of-care products in our portfolios, particularly around connectivity, and certainly brings many synergies which you have experienced and will continue to experience in the future. Radiometer is very much embedded in many of your hospitals, and we're being asked to provide an ever-increasing test repertoire as the demands for point-of-care exceed many of the requirements over the very, very busy times that we see. When we look at blood gas, particularly when you look at the ABL 90, that's very much the case when we look at creatinine and urea. An increasing number of EDs have added these parameters in order to help manage their patient throughputs. For example, reducing delays in scanning have certainly helped by having access to creatinine and an EGFR in only 35 seconds, and that's undoubtedly proved to be very, very helpful. Customers have integrated blood gas creatinine into their renal pathways and also to their AKI scoring systems. And certainly when it comes to sepsis management, being able to have that information more readily for renal function has helped with the prescription and getting the dosing right as far as gentamicin is concerned. Also, when it comes to urea, what we found is that's a benefit in supporting pathways related to pneumonia, for example, the curb scoring system, and also when it comes to upper gastric bleeds, and that's where the Glasgow-Blatchford pathway comes into play. Of course, the results you get are only as good as the samples you take, and many of you are very aware of that. And by the use of products such as the Safe Pico sampler that we have, we can help to reduce the air bubbles and the inconsistent mixing that sometimes are seen in the point of care setting. And by having that venting tip cap, which you can see on the screen, also means that you don't need to decap the sample and you can reduce the potential for sort of harmful blood exposures. There's also the mixing ball inside, as you can see, and that, when combined with the device itself, allows for homogeneous mixing of samples and certainly to ensure you can get a laboratory standard hemoglobin result. When it comes to immunoassay, again, a number of you will be familiar with the AQT. What we're seeing is that procalcitonin is certainly the new kid on the block when it comes to infection markers, but you can also get a CRP on the analyzer as well. And particularly at the moment, D-dimer has seen an increased adoption. With only 20 minutes for its turnaround time, you can get ED staff with that critical coagulation information that they need, particularly with some of the patients they're experiencing at the moment. And also NT-proBNP is another parameter that's available on the AQT. The great thing with the AQT 90 is that it's got a very similar interface to the ABL 90. So if the department has that instrument currently, this is actually a very straightforward system to integrate. And the great thing is that all the tests that we measure can actually be measured on an EDTA sample. Now, critically, of course, to keep the show on the road, it's really key that you're able to see what's going on, and particularly when you've got installations spread across extensive parts of the hospitals, using a Cure, our middleware system, can really help to ensure that you've got the system under control. Certainly, when it comes to accreditation, a Cure can really help with, for example, recording compliance issues, automatic operator recertification, and standard reports like uncertainty of QC measurement. Now, undoubtedly, COVID has brought many challenges when it comes to managing analyzer uptime, and keeping the service running whilst not having access to red areas can really compound that situation. Now, a Cure can help to keep you in control, but also Live Connect, which is something that our engineers can use, really comes into its own. We've got over 80% of our analyzers connected, which allows our engineers to actually check these analyzers remotely and therefore hopefully avoid actually attending site in many instances. And that's a 24/7 monitoring capability, which is really very, very useful. That can certainly help in terms of fixed times, improving those, but it also means it reduces yourselves and our team in actually having to go into infectious areas. And there are also components of Live Connect, which can also help with the accreditation piece. Now, history undoubtedly has a habit of repeating itself. And back in 1954, Radiometer was approached by the Danish biochemist Dr. Paul Astrup to develop an apparatus to measure PCO2 and calculate acid-base parameters during the polio epidemic in Denmark. And this, in fact, led us to developing the world's first blood gas analyzer. So it's interesting that 66 years later, we've been called upon to support the COVID-19 pandemic. We're certainly very pleased to be able to have done that and very humbled to have worked and experienced the challenges that you have had to go through during this time. And that's really been a very, humbling experience, as I said. We certainly don't know what's around the corner, but the critical thing is that whatever comes next, we will certainly make sure that life comes first. Thank you.
Thank you, Kevin. That was brilliant. So it is now my pleasure to introduce the wonderful Katy Heaney, who is going to be delivering the next presentation. Over to you, Katy.
Thank you, Hope. Okay. Good afternoon, everybody. My name is Katy Heaney. I am a point of care testing consultant lead for Berkshire and Surrey Pathology Services. This is a joint venture of 4 accrued NHS Foundation trusts, Ashford and St Peters, the Royal Surrey Foundation Trust, Royal Berkshire and Frimley Health. We have 5 acute sites as part of that service, and I am the consultant lead of, very luckily, a large point of care team that covers all of those services. So I would say from that, I have lots of experience to bring to the table with you. I've been working in the point of care field now for over 15 years and in the NHS as part of that, but also in other joint venture private partnership services as well. I love point of care. I'm really passionate about it. And I hope from today's session, you'll get the things out of it that you want, but ultimately, please do put questions in the chat box and in the Q&A box. At the minute, I can't see the chat box as I'm speaking, but so I might have to come to your chat and questions at the end, and I'm sure Hope will help us with that. Okay, so the summary of my talk today is really what was the impact of COVID-19 specifically on point of care testing services. It's a question I've struggled to answer in a 35-minute session, but I'll tell you where I started with. How are we maintaining and developing those services? And ultimately, what is the future of our service beyond COVID-19, if there is such a time, or certainly what's next, I guess, is more the question. So to put it into some context, I thought I'd just tell you what is our point of care testing service. So our PSCT service is ultimately responsible for the training of using the devices, the maintenance of those devices, quality control monitoring. So the majority of our devices, we request that the users themselves run their internal quality control, and we send them external quality assessment. And in fact, we have we run an external quality assessment scheme called Qpoint, specifically designed for point of care testing devices. We do their stock control, we manage deployment of new kit, troubleshooting and breakdown, and ultimately the IT integration, so getting results into the electronic patient record. So that's kind of a quick run through summary of the kind of headlines of what we do and what is our service about. And then next to that, I've put you there a list of the point of care devices that we have across our services. It's not quite 100%, but it's probably a good 85–90% of what our services are about. It's a very broad range. Some of those are used in acute settings, some of them are used in outpatients, some of the used are everywhere and anywhere. And the volumes of how they're used and things like that also depend on the number of patients coming through and that kind of thing. So just to give you some context about that really, what is our service and what it's about and what do we look after? Who is that done by? So we have myself as the consultant clinical lead. I have some clinical scientists that work for me as well. We have biomedical scientists as general managers, cross-site managers, and each site has a lead coordinator for point of care testing, and that is a biomedical scientist. We also have then coming through the routes of the service, quality support officers, associate practitioners, and medical laboratory assistants. And we support them with portfolios and career development according to what their needs are and what they want to do, but ultimately to help us grow our own as we want to develop people in our service of all grades. We also have some administration support. We have some secretarial support, not as much of it as we might like, but some. And that helps us. We've got to register here. We are covering 5 acute hospitals. This is a large service. We have a network approach, which in the UK, pathology services are divided up in NHS England into 29 networks within England. And our sites consist of one of those networks, South 5. So 4 trusts, but 5 acute hospitals in that. And what that gives us is this huge strength in our size and what it brings with it. We have a massive knowledge base. And by that, I mean, we have access to the clinical leads in all of those different departments. We can come together with some amazing consensus opinions, most of the time, on how we want to run services and how to move things forward. But that expertise is invaluable. We also have some good buying power by way of the amount of devices we have and the amount of tests we run. We push for the harmonisation of service because we recognise we want to follow the evidence. We want to allow people to have a kind of standard. If I run a blood gas, I would expect this to come out of it. Rather than if I move to one device on one place and one device on the other, I might get something slightly different. If the evidence is there, we should be following the evidence and providing that service at a standardised level. We also, by way of having a network approach, share the burden of service delivery. And I hope I'll come on to later why during COVID, this was critical to us in that it gave us a huge amount of flexibility and robustness within our service. The other strength that we have is our multidisciplinary approach. Our biomedical scientists, our point of care coordinator leads, are all from different pathology disciplines. We have biochemistry, hematology, blood transfusion, virology, and we also have microbiology within there too. And this brings with them all of the different knowledge base from those pathology departments and their backgrounds and their routine laboratory roles and tests and understanding. And then we apply it with the shared skills around running a point of care testing service. And that is an enormous strength to us. And you can imagine that virology BMS was absolutely key for us being able to support a point of care service through the COVID-19 impact. Okay. So what was the impact? I have very deliberately left this slide blank because while putting together this presentation, I've spent a long time staring at the screen and saying, how could I really describe everything that's happened to us in the last year on one slide or in several slides? And my answer to that, I'm afraid, is it's impossible. It has been both catastrophic in terms of just completely and utterly changing the way that we work, but also an incredible exponential learning curve on how to develop a service, how to change your plans and how to be flexible. So we have both imploded and exploded simultaneously at the same time. And I just couldn't find a picture good enough to describe that on the screen. So I've left it blank and hopefully we'll come back to it in a moment and I'll show you how it is I came to be able to put some answers on that slide. So let's start where we can. It's a respiratory disease. COVID-19 is a respiratory disease, and as part of that, it is critical for patients to have a blood gas analysis to understand their current baseline position and how their disease develops. So what that meant was a huge increase in the number of tests that needed to be done for our admitted patients. The balance of the number of respiratory patients in our service, in our ITUs, increased extraordinarily in comparison to the number of patients admitted. We had an increase in testing locations. So we hear a lot on the news how our ITUs have expanded. And ultimately, there's only so far that it's reasonable for a member of staff to walk to reach that blood gas analyzer. And in addition to that, we had to consider the infection control risk of that member of staff moving through several different departments, perhaps even moving from a hot zone to a cold zone. And the burden of having to change PPE in the middle of that just to run a sample was unacceptable. So we had to increase the number of testing locations. We had an increase in the number of users of the devices because the staff needed to support those patients, increase the number of staff therefore needing to use our devices. An increase in stock requirements, which I'll come on to in a moment, which is one of the most difficult challenges to judge and predict as we have gone through 2020 and is still an ongoing issue. And we also had this potential unknown effect of the disease on the patient's blood sample itself. How would it change the blood sample? We knew about the infectivity of it, but as we started to learn more about the coagulation, the clotting of that sample, and that's potential effects on an analyzer such as a blood gas analyzer could be catastrophic. So on this slide here, and I hope you're able to see it, I've plotted out for you the number of blood gas analyzer tests done in the ED departments, that's the emergency department, done in ITU, and then done in some other areas like labour ward and the neonatal unit throughout the course of 2020. And you can see in December 19, then our biggest user is the emergency department, up here at 5,500 per month, and the ITU department at around 2,000 per month. And then you can see how these track, where in the UK, our wave one sort of climax, if you like, was March and April time. You had this doubling of the number of tests per month being run in ITU. But you also had this drop off of tests being done in the emergency department. In the UK, we really suffered from people shying away from coming to the emergency department, even when they were critically ill. They were frightened ultimately of catching COVID if they came in. And so we actually saw a drop off of the number of patients coming through the emergency department. And then as that wave one broke and our lockdowns kicked in, we had this drop off again of the number of patients being tested and this slow gradual increase back up to normal levels in the emergency department by the time we get to August and September time. What's been different about for us, what we would call classically the wave two in November and December, is you can see that climb there in ITU again. So we've got this increase in ITU admissions, doubling the number of tests that we do per month, but we have not seen that drop in A&E department attendances requiring a blood gas analysis. So I hope what this graph will show you is just how difficult it has been to judge stock requirement, to judge testing needs. It's been a real challenge for us and a challenge ultimately for the manufacturers of blood gas analyzers in the UK and globally to understand that need and ultimately predict stock requirements for sites. And I would urge any of you working in the point of care departments just to take a moment to reflect on this, because whenever you come up to renewing your contracts or anything like that, you will need to look past over what has your workload been over a period of time. And 2020 is not a good year to judge your future workloads because it was so changeable throughout the course of the year. We had an increase in testing locations, and this was mainly based around expansion of the ITU service. But as I said, this crossing boundaries between hot and cold areas became a real issue, particularly when there were some constraints over the availability of PPE. So we had to consider that. We had to try and split devices up. Now for us, our service was set up so that high use areas had 2 blood gas analyzers. This allowed them to have a robust service. If one went down, there was always the availability of the second machine. So we took the decision to split those pairs up in order to provide those additional testing locations. We, in addition, managed to discover 3 old modelled blood gas analyzers in the basement of one of our sites, which were due to be auctioned away, and put those back into service, and we named them the Phoenix analyzers coming out of the flames. So that allowed us to have a bit more flexibility across our sites. We placed our order, as did many other people, for additional blood gas analyzers, and we waited. And those regretfully did not come through during wave 1. They came through in September time, and we were able to put them in place, and they have given us a huge support for wave 2 and being able to spread those locations out. However, by splitting up that pairing, what we created was a risk. We now created a risk whereby we might have an urgent care area whose machine went down, and therefore they don't have local access to a machine. And with the PPE boundaries, this was even a higher risk than it might have been prior to that. So we were pleased ultimately during COVID, we ended up sticking to our policy. We were able to train all of those additional people that came in to work in the IT and the critical care departments. We provided training at weekends, we provided training early in the day and late in the day. And again, that was something that came out of our ability to spread our staffing hours on site out. We responded to those requests for open access by giving them alternative solutions. There was lots of saying, I can't get my badge out of my PPE, so how can I get it out and then scan it into the gas machine? So one of the solutions that one of our junior staff came up with was that there are a particular type of pathology transport bags that have a sealable bag side and then another side with a kind of sleeve. And if you put your arm all the way through it, you could actually put your badge into the sealable side of it so that it was out on the outside of your PPE. And that would allow you then to have the scannable part to access the machine. And some of our sites took that on board and loved it. And they also used it to hold their ID in there to help people see who they were. And we had other sites which used a system of badges would be kept next to the machine, but ultimately under the control of the ITU matron or something for the shift. There were lots of different innovative ways to doing that, but we kept our policy, which is not to allow just anybody to use the machine. Only trained staff are able to use our blood gas analyzer machine, because ultimately the risk of damaging it meant that an entire unit would lose the ability to use that machine just from that one episode. Okay, stock management. You can see there when I showed you all those test changes, that was just one site. But this is a huge pressure ultimately for blood gas analyzer manufacturers, for both reagent and for the plastics, the syringes themselves. And we were informed last year that Radiometer had made their choice to prioritise some mass production over the production of urea and creatinine cassettes. And we used our urea and creatinine cassettes in our emergency department to help with the rapid provision of a renal marker for patients. And ultimately, by removing the ability to give that on the blood gas analyzer, it introduced a risk for that patient group. Now, that's not to say that everybody that comes through the A&E door who gets a blood gas analyzer test requires a creatinine. But there are some groups whereby the risk of them not having it is very high, and we felt we had to do something about that. So we implemented during that time a rapid creatinine point of care service for those selected patients. We had a dedicated point of care staff group in the emergency department at the time, which I'll come on to later because that's related to our COVID testing. And the sample could be taken in the emergency department, given to the testing room, and we were able to report something within 20 minutes. Now, we could have rolled that service out and attempted to train up all of the nursing staff in the whole of the department to run that. But frankly, you have to work in collaboration with your clinical care department over what capacity do they have to implement something like that. And ultimately, we felt that this staff group was able to provide that service without putting the burden onto those nursing staff to have to run it. And it meant that we were able to monitor it, to electronically report it, and do all of the training for those staff groups. We had this service set up in about a week and a half once we were unable to provide it through the blood gas machine. And when it came back on the blood gas machine, we were able then to withdraw it and go back to our standard of care. Now, there was obviously an infection risk to our staff. Our point of care staff are travelling around clinical sites, having to visit both hot and cold areas. They were having quite a lot of clinical staff contact during all of the training that they were doing. Some of that was in very small staff groups and, you know, in close proximity, you know, huddled around a machine to look at the screen while you're training and that kind of thing. And we were ultimately ourselves a small staff group, but critical. So what did we do about that? So our staff had full PPE training and fit testing for all their masks. We were very lucky to be able to get that actually from some of the military staff who work at Frimley Health, who were part of the team that went out to Africa to deal with the Ebola crisis. So you certainly felt very reassured that if they were able to go out there and use their PPE successfully to avoid getting Ebola, then they would be able to support us to avoid getting COVID. We wrote up a site contingency document. So if the team on one acute site were all taken ill or all unable to work, a member of staff from another acute site within our network was able to turn up at the day, pick up that document and run all the necessary business as usual tasks to keep that service going by just following that one document. They would know the SOPs, they would know all of the processes because we all use the same harmonized processes across all of our sites. But those little bits of location specific information, where's the key for that? What's the code for that door? All of that kind of thing was all on that one document. So we were very prepared to have that cross-site coverage if it was required. We put a stop to any unnecessary cross-site travel. So as a senior team within point of care, we would have a monthly meeting where we'd all come together, for example, to discuss development of service and that kind of thing. So that was all put a stop to. And where we did have members of staff that would cover 2 sites at a time within their role, we asked them to just stay with that one site and remotely work for the other site. Our meetings went virtual. And in fact, I was reflecting yesterday how amusing it was that when our meetings went virtual the first time, we went on to conference calls and the conference call provider was then suddenly unable to provide any calls on the clock hour because everybody had scheduled them all for the same time. So I still have hanging in my diary some meetings which were scheduled for 22 minutes past the hour deliberately so that we were able to log on to them and actually get through to the call. Whereas of course now we are using MS Teams and we're able to see each other's faces and we have not had any of those same problems in terms of logging on the clock hour. This, however, of course, created a risk of isolating our staff, of making us not feel like that cross-site big team. And we were very concerned about that. We felt it was really important for the mental health of our staff to show them that we were still that one team. We were there to support them. That just because their manager wasn't on their site or their senior team wasn't on their site, it didn't mean that we weren't there with them on their shoulder working alongside them. So what we did about that, we had a daily check-in call, 30 minutes, all members of staff to join. How are we all? A quick whiz around all of the sites, just with items by exception, and move on with our day. It was really important. It just kept us all on the right track, on the same track, moving in the same direction. We had a weekly session with the senior team members where we had focused topics about COVID, what was coming up, what new guidance had come out along the way. It was really important to keep in touch with that. And particularly for our senior team, because we were a cross-trust service, each trust would come out with very slightly different guidance on something, and we'd have to try and pull it together and make sure we were fulfilling all of their requirements as one service. And that was a challenge. The leadership team, myself included, we were ultimately encouraged to use the time in those meetings, not just to talk about service, but to ask people how they were. How are you doing? How is your day? How are you feeling about things? It was really important because if you were meeting with people face to face, you would naturally do so when you came into a room. And just because you're in an MS Teams meeting doesn't mean that that piece should be lost. We encouraged open and transparent conversations, talking through decisions, reminding ourselves to be flexible. There was no point in gluing ourselves to a trajectory which ultimately might be taken away from underneath us. We needed to work flexibly, and we need to recognise the challenge. And I say this because I think it's really important. This was a really difficult time for pathology services, NHS services, and indeed the entire world. And there was no point in pretending things were normal. There was no point in pretending things were going to be okay by the following week. And we needed to talk about it. And for those of you who've seen me talk before, you may have seen this particular diagram, which means a lot to me. It was something I saw very early on in the pandemic in the UK. And it just talks about what kind of person do you want to be during the pandemic, during this challenge. The growth zone is the place where we all want to be, to live in the present, to be empathetic, to thank and appreciate others, to look to adapt to change, to be flexible. And we can all move into the fear zone when things got on top of us, when things became difficult. And it's okay to do so, as long as we recognise that we're there, and then we try and move ourselves back to that growth. It also helped us deal with other people within the trusts or within our services or people around us, family members included, who were themselves struggling, is just recognising that they at that time were in the fear zone. It was okay for their objection or their upset. We needed to help them see through that and get out of that if possible. Okay. So this takes me back to that original slide, which I had at the beginning was blank. And I hope I've given you some sort of understanding here that point of care testing service, there was a huge increase in the need of our service. There was a lot of risk associated with our service, associated with the original service, but also some of the changes that we had to make to the service. And we constantly assessed and mitigated against those risks. We had a live risk register that we went back to 2 or 3 times a week, just going through, where are we on this? Is this still a risk? Has this risk escalated higher? And just talking about that as a group, seeing it down on paper made us all feel a lot more like we could sleep at night because we were talking through those risks together as a team. That team working, collaboration and consultation is just critical. And I really feel for point of care staff out there who may be working as single-handed or in very small, a team of 2. And I hope that our point of care networks, we were ultimately able to reach out and support those people, because we are here nationally to work together in our National Health Service. And lastly, I guess on the impact, it's not finished yet. So the infection risk about samples was also there, and there was a lot of kind of conflicting policy or very rapid policy changes at the beginning of the COVID-19 pandemic about what the viral content was of bodily fluids, of blood samples, of urine samples, respiratory samples. And we ultimately had to just deal with those policies as they come. As new evidence and information came to us, we carried on dealing with it. Our risk assessments, we assessed who was doing what, where, when, what were they wearing at the time? How could we reduce that risk? And ultimately, if the risk of running that sample outweighed the benefit of the patient having that result, we would take that machine out of service. But you'll find for a lot of point of care testing, those devices are there for a reason. They are there to support patient care. And they should be there because ultimately they have an impact on the patient's journey and potentially the patient's outcome. So ultimately, we did not withdraw equipment. We carried on using our equipment in a risk mitigated and understood way. We recognised what the risks were to our own staff members, and we also recognised what the risks were to the device users. And we engaged with them and their infection control teams about mitigating that risk to look after them in the best way we were able. So I couldn't do this talk without talking to you about point of care COVID testing itself. As a substantial point of care testing network, we ultimately prepared a strategy for doing this as quickly as possible when the start of the pandemic happened. We knew there was a need for rapid tests. We knew there was a need for cohorting, and we were offered the opportunity for the Samba device in April of 2020. And these are some pictures of our service. So the Samba 2 devices produced by Diagnostics in the real world were offered to us from a centralised contract by the Department of Health. They offer a COVID test in 98 minutes analytical time. You load them one by one. And we set up those services from scratch. From the offer to the first service go live was 3 weeks. And we worked incredibly hard in that time. There's no way it was 3 weeks of working hours, that's for sure. It was weekends, it was overnight, it was everything that we could do in order to provide this service. The location ended up in the emergency department. We had rooms converted to allow us to do them. We had a dedicated team of staff. Ultimately, some people can argue with me whether it's point of care, whether it's a hot lab, depending on who hires the staff. I don't have time for those conversations in that time, in April, we met with our ED department and we said, right, who's got capacity? And I tell you right now, they were desperate for hiring new nursing staff and healthcare assistants, and I wasn't going to take those staff away from looking after patients. So we took the decision to hire them within the point of care testing team. And those staff work full time within the emergency department. It's just they are managed by a point of care team. The devices, like I said, DRW Samba, we report manually into our laboratory information system. We did a verification with retrospective and prospective samples, which was obviously successful. We were offered the kits, like I said, 3 weeks we were live. So that service now, each of our acute sites has a Samba service. We have 42 devices in total across those 5 sites. We run on average 450 tests a day. Our average turnaround time from swab to result is 2 hours and 46 minutes, which we are very proud of. In the 6 months of service, we estimate we've run 36,000 patient tests. And I'm sure once we reach 12 months of service, it will be significantly more than double than that. It's a service we're incredibly proud of. I have written an article in the Royal College of Pathologists Bulletin about the service, if you're interested in seeing more details on that. It's something we feel has had a huge impact in our site's ability to cohort and manage patients and ultimately provide the very best quality of care that we were able to. In December of 2020, we added the addition of the Roche Liat. This provides a multiplex test of flu A, flu B and COVID-19, which we affectionately call the FABCO. This has an analytical time of 20 minutes, so a lot shorter than the Samba, but there is very limited stock in the UK. Our sites have around 25 tests of these a day. And again, we've put them into those ED testing rooms with that dedicated team of staff. And so from the arrival of reagent to the day we're able to go live was approximately 4 working days. We can move quickly because we have that dedicated team of staff. My reflections on that is about, like I said, that dedicated team has allowed us to be super flexible. It's allowed us to add new kit, take out new kit, change our ways of working, reflect policy. It's been fantastic. It has standardized and made our reporting consistent. It means that we know our results are feeding into Public Health England for all of our patient tests. We know all of our results are on the patient's records. And it ultimately permits this network-wide approach to testing, in that we can learn from each other in our service and the size of it. I would reflect that running a rota for 5 sites of 24/7, we might have originally thought that would only take us 35 whole-time equivalent staff members, but during a pandemic with sickness and isolation, staff turnover, it's probably closer to 50 actually required in order to run the service in a successful and robust way. So we have had a huge recruitment piece on our laps, and it has been fantastic to see all of those people come through from lots of different backgrounds, and now able to offer them fixed term contracts and ultimately develop them in their careers. And I'm sure a number of them are wanting to stay within the pathology remit. We have grown our own point of care testing teams, but also other people going into the NHS who have a background now in pathology and how it works. The future of this service for point of care COVID testing, I think my reflection on that is we had already instigated an annual rapid testing for flu, bringing it in at that winter pressure and that winter season. And I suspect something like that will develop for COVID as time goes by. I think the ability to multiplex, to run several tests at the same time on the same piece of reagent is important, particularly when respiratory diseases, the symptoms overlap in such a way. And ultimately, the ability to potentially do even more infectious disease testing at the point of care can be shown to be important to reduce nosocomial infection within the hospitals. Our dedicated team ultimately has allowed us to do a whole host of other things. We have been involved in research studies, we have had flexibility, and we've ultimately been able to train them up to also support other acute point of care testing equipment at 2 AM that has gone down. So we've got a lot out of that team, and I'd really encourage point of care services now across the country to consider whether this is an option for them to provide a really robust service for their acute teams. So in my last section on this, I'm aware that time is ticking by, I'm sure Hope and Daisy are messaging me thinking about it, is to talk about the future of point of care testing services, because it's not really post-COVID. We're not there yet, are we? We are still in COVID. How much post-COVID will we be? But ultimately, this report was written by Sir Mike Richards, the Recovery and Renewal Report for Diagnostics. Released in October 2020, it has an entire appendix dedicated to point of care testing services and the direction of travel in which they should be taken. It talks about separating acute work from elective diagnostics. It talks about diagnostic hubs, again, away from acute hospitals. And it talks about organising diagnostics so that a patient only attends once, not coming back and forth. And therefore there will be a huge increase in a requirement for point of care tests on those patients in order that decisions can be made at the time of their attendance. In the appendix then, it talks about a whole host of different settings where we should be considering putting point of care tests and how we support those. This is a real opportunity here to reach out outside of our acute sites to GP practices, to care homes, and really thinking about what's the best test to go into them to have impact, what would allow a decision to be made. And point of care testing teams have so much to offer in supporting those services. In that appendix, it also lists a number of tests that it suggests would be useful and some of the use cases for those, which I've highlighted for you there in yellow. We know some of those are available already, some of those we're already running in our acute sites, but how could we also offer them in those diagnostic hubs and to patients to avoid them coming back over and over again? The NT-proBNP is a good one for cardiac failure clinics or query cardiac failure clinics for consideration. We know INR, huge increases for INR testing, D-dimer as well, if you can bring it together with the imaging for DVT to allow a better decision to be made over those patients at the time. I think that's a fantastic use of point of care service. And the last part on that appendix is talking about the barriers and what are those barriers and how can we overcome them. And specifically it states that local pathology laboratories should be involved in those discussions. So this is your opportunity, point of care leads, to get out there, to say, look at this report. This report says we should be discussing this. And I'm sure those people would welcome your input, as ultimately, if you are a point of care lead or you're working in pathology and point of care, you are the expert knowledge in these devices and how to set them up. What do they require? What do they need on location and in the room? And people will welcome that knowledge. And I urge you all to go forward and to do this. So how will they continue? So I think that COVID-19 has improved the recognition of pathology as a whole, but a huge recognition for point of care testing. Could we believe that on BBC News, the Prime Minister uttered the word point of care testing? I nearly fell off my sofa. Just amazing to see our profile lifted in such a way and recognise the need for us. And I think that will continue if we continue to show how we can be used in now different ways, not just for COVID testing. This is the time for your business cases. Look at those new staff, look for those new opportunities. See you coming on, hope. So I'm moving on to my last bit. And celebrate your achievements. So this was our BSPS achievement board of what we did in wave one, all of the things that we were successful of, all of the things that we did in order to meet that challenge. And I urge you all to think about how you can celebrate your own achievements, because if you're not the one screaming and shouting about it, nobody else is going to. That's my last slide, and I'll just say thank you to all of those who have supported me and our team and everybody ultimately that did the best with what they were faced with. Thank you very much.
That's been brilliant. Thank you so much, Katy. We've got lots and lots of questions coming through. So if I could invite David, Kevin and Paul back on screen, and I'll get going through some of the questions. So the first question is, in offering your fixed term contracts to build beyond your pre-COVID point of care team, did you use pathology-based job descriptions or a more generalised healthcare professional description to attract staff with experience outside of pathology?
So we use an associate practitioner job description, so they were pathology based. We found we had a lot of students in the first wave coming through looking for that laboratory experience. And then in our second and third wave of recruitment, because we've had several waves of recruitment to support the service, we've had people come from all sorts of different backgrounds. So people, we've had some air stewards and air stewardesses. We've had people who have had sort of quality backgrounds in terms of, quality reporting, quality services, people with an IT background as well. It's been very varied because ultimately we can offer them the training in order to do the job that we do. We're not expecting independent working out of those grades. And some of those people have brought a really fantastic experience of their own to those roles. It's been a real eye-opener.
That's brilliant. Thanks, Katy. So the next question is, how did you fund all of this extra kit and staff?
So the Department of Health contracts ultimately is paying for the point of care testing equipment, and that is given to you as part of that national equipment. The ongoing funding for that, of course, is still a discussion and to be held by the central teams. In terms of the funding for staffing, we made our cases to our kind of gold command structures within the trust to show them why it is that those staff members were needed to run the services. And when you point out, well, I can offer you a point of care COVID test in 2.5 hours versus the 8 hours you might be looking for, they can recognise the benefits downstream to that and they are willing to invest. You've just got to find the right person to ask and pose that question correctly, which has been my experience.
That's brilliant. In identifying those additional risks, did you then review the risk regularly, making further changes as appropriate?
Yes, absolutely, Tony. I mean, I remember some points we were looking at it on a daily basis at those risks. Where were we? had policies changed around us, had infection control updated something. You can imagine having to do that for 4 different trusts made us very wary of potentially missing a piece of critical information and therefore not following a policy. So we did spend a lot of time investing into those registers and monitoring them and version control on them and that kind of thing. It was really critical to us, but it was such an important part of keeping our staff safe that we did invest that time.
Brilliant. And how did you deal with staff accessing their barcodes under full PPE?
So I did talk a little bit about the kind of the plastic bag part of coming up their arm and being able to kind of tuck it into that. So that was one method that a site used. There was that other site who would have everybody would come in to shift and their barcodes would be managed next to the machine by the matron. There were lots of different ways about it. People found ways. I think it was about really responding to those requests for open access by displaying to them what risks that would bring, and the risks that were about damaging of their critical equipment really made them think about, actually, maybe this isn't the way to go and we need to find a different way of working. So I think it's about having the confidence to stand up for your equipment and what the consequences of breaking that could be is really important.
Okay, that's really helpful, thank you. How did you accommodate extra training without crowding the analysers and trying to maintain distance?
So no doubt it was difficult. We ran lots of back-to-back sessions with smaller groups with distance maintained as much as possible. So our staff members would stand next to the machine, and then when people needed to look closer, we would stand back. We had a kind of Strictly Come Dancing movement around the analysers to kind of keep yourself back and forth. We have now looked at some remote training that we're able to give on some sites that have really struggled. So that there's lots of different options out there, but yeah, I agree, it is a risk. It's something that you do need to carefully consider.
Okay, that's brilliant, thank you. How have all the changes during COVID affected your staff engagement and morale?
It's been hard. It's been hard, but I think that as a leadership team, we took it very seriously about how to keep our staff engaged, of looking out for one another, of just keeping in touch and talking about when people are having a difficult time. I take it very seriously, my role as a leader, to demonstrate that when things are not all perfect with me, there's nothing wrong with putting my hand up and saying that it's not, and just demonstrate that humanness about it, I think is really important. Finding an opportunity for people to raise their concerns and worries in whatever forum it is that they feel comfortable with as well. You know, you can't push everybody into talking about what they're struggling with, but you can give them opportunities for discussion. You know, we would send maybe diagrams to each other or you know, phrases or things to discuss in smaller groups and that kind of thing, so that people felt that opportunity to answer it. But ultimately our trusts did provide a large amount of wellbeing support as well, which people could access.
Okay, that's brilliant, thank you. We've got some questions for Radiometer coming up. So can you connect Radiometer devices to middleware that is non-Radiometer?
So yes, you can. There's usually a loss of some functionality if you don't connect them to a cure. And we're usually talking about operator management and then device control, but you can certainly connect them to lots of other systems and get their data sent to wherever you want. Okay,
thank you. And what is the benefit of using Setonin over CRP in the management of sepsis?
CRP is generally seen as an inflammation marker, whereas Setonin is a bit more specific for infection. So you're getting slightly more useful, if that's right. Is that the right phrase to use? Information using Setonin. It's not as widely adopted in the UK, but certainly is in Europe and elsewhere in the world.
Okay, that's brilliant. Thank you. Paul, is there a driver for the Gen Expert?
Yes.
Okay. Wonderful.
keep my answer short.
Thank you. Katy, would you be able to share your site contingency plan?
I can certainly share the template for it. The details on it would be a bit confidential, but the template for it, and yes, I'll put that in as part of the end of the slide presentation so people can see just the kind of things that we covered on it. But it really was an example of, if I walked in the door, what are the first things that I do? What's the highest priority? What, you know, if I've only got the ability to work here for 2 hours and I need to make sure the service is going to continue, what do I do first? So it's about that, and that's, you know, it's written by the people who run the site day to day, but ultimately for the eyes of someone who doesn't.
Okay, that's brilliant, thank you. This one's for Radiometer. Can you connect COVID instruments to a cure?
Yes, you can. So we've got drivers for different devices and solutions ready.
Thank you. How regularly do you provide device drivers for a cure?
So we have 2 or 3 group releases of drivers each year, and that's for new drivers and updated drivers. We do carry out lifecycle management of the drivers, so we'll add new functionality whenever that's available on the instruments. We develop drivers for UK and Irish customers, and what we're launching this year is that local driver development as well, so we can develop drivers here in the UK for market needs rather than waiting for a global demand for a certain device.
Okay, that's brilliant, thank you. Are the Samba COVID tests, in addition to a lab-based PCR testing through biology?
So yes, we in addition, we have one of our sites has our virology department for centralised high throughput testing, and then we have rapid on-site testing provided by the Samba and the LIAT. So it's a combination.
That's brilliant, thank you. We've answered quite a lot of these. Can you say how often a patient will be tested on a blood gas analyzer in a typical day, thinking particularly of patients who are receiving oxygen compared with patients on ventilators or those who are in recovery?
So I would say, in my experience in ITU, most of them tend to have a kind of 4-hourly testing regime for the most critical of patients. But for more of an HDU, so a slightly stepped down process, you might have 3 times or twice a day, that kind of thing. That tends to be what's used, but it is a very local decision.
Okay, thank you. And what is the sample volume for creatine and urea measurement?
Okay, on the ABL 90 blood gas analyzer, it's a 65 microliter sample, and that will give you your gases, electrolytes, coax, a glucose lactate, and a creatine and urea. So just 65 microliters. So that's ideal for both adults, kids, babies.
Okay, that's really helpful, thank you. And I think we've just got time to squeeze in one final question, and I must let you all go because I know that we're running over. Someone's asked that they would be interested in your point of view, Katy, regarding the ongoing risk for sites which have non-existent point of care setups. Their trust has been regarding point of care this last year, and it's been set up, supported via a part of an 8A role and a willing and able clinical scientist volunteer. They've seen a 50% increase of blood gas analyzer provision and a multiple ACOV2 point of care platforms, but they're desperate to raise the clinical risk awareness of point of care testing post-COVID, and how all this extra kit cannot be supported by the current personnel setup. And I'd like to find out a bit more about the steps that are taken robustly to facilitate both the interest and investment from the trust.
Firstly, my sympathy to you, Jeff, and your team there. It's a difficult one, but ultimately I bet you proved your worth. I bet you can write a series of vignettes or examples of what it is that you've done to make an impact on that service and on your trust by doing even the amount that you have done. And I guess it's about up and demonstrating what more you could do if you had more staff members dedicated to that service. And I think that using the Mike Richards report, you know, using any business cases you're able to get hold of, the point of care manual has a series of them, you know, as part of that, people are able to share, is putting together what do you think the site does need, and then how much that would cost them, and then what benefits they would get out of that, and what risks would be present if they didn't. And I think this is, I would call it the time to strike. Get out there, show your work, all of that wonderful work that you have, and how, if you weren't there, what might have happened, what might have been the consequence. And get that up as high as you possibly can. Find a clinical champion, find a clinical director or an ops manager champion who can help you take that up to board and get that approved and viewed and talked about. And I hope you're able to find the support from that you need. But I think this is the time. Stand up, shout with us. Point of care rule.
Thank you. Thanks, Katie. I think that's a lovely and inspiring way to end today's webinar. So thank you so much for delivering such an informative presentation. I can see lots of comments of thanks coming in. Kevin, Paul and David, thank you so much as well. And thank you to Radiometer for kindly sponsoring this webinar.